It's one of my favorite topics to work with students about and other professionals. So I was excited to hear that you all were interested in this topic as well. Um, Connie is correct. I recently accepted a job with the University of Alabama at Birmingham, which is a large teaching hospital in the southeastern United States. I have not started there. I start on Monday, so I did not put that on my slides. I'm just representing myself today. And I'm presenting to you from my kitchen table, so I'm hopeful that the Wi-Fi and the audio and everything goes smoothly. Please let me know right away if there are any difficulties, and I will try to troubleshoot. So the topic today is evaluation and treatment of dysphagia in people with a tracheostomy. Going to see how to, there we go. The learning objectives for today, I divided the presentation up into 4 parts. So in the first part, we'll just kind of review tracheostomies in general. We'll talk about indications for a tracheotomy procedure, the function of tracheostomy tubes, and the types of tracheostomy tubes that you may encounter in your practice. In the second part, we'll briefly overview of the literature about dysphagia in tracheostomy. There is a lot out there, and I've tried to distill it down into some take-home messages for us as practicing clinicians. And we'll talk about the causes of dysphagia in the setting of tracheostomy. In the third part, we'll talk about evaluation and treatment of patients who have a tracheostomy who also have dysphagia. In part 4, I hope will be pretty interesting. My partner is a head and neck cancer surgeon, and he kindly provided some images and some case examples of patients who required surgical tracheostomy. And I'm hoping that when we get to that stage, we can look at the pictures and discuss those patients and apply some of the information from the previous parts to think about how or why these patients may have dysphagia that co-occurs with their tracheostomy. And I'm aiming to leave about 20 minutes at the end of the presentation, either for questions or to give you back the gift of time if there are no questions. So jumping right into part 1, a brief overview of tracheostomy. And I want to make a small just point of semantics here. You'll hear me use the terms tracheotomy with a T in the middle and tracheostomy with an S in the middle almost interchangeably during this presentation. Technically, the way most people regard it is that the tracheotomy is the procedure to create the tracheostomy, which is what the patient is left with. There are some people in the literature who quibble that a tracheostomy is not a true stoma because there's not adhesion between the skin and the membrane, the mucous membrane. And for the purposes of this presentation, I use the terms fairly interchangeably. So, indications for a tracheotomy procedure. This is a heterogeneous patient population. The most common reason that I encounter in my clinical practice is patients who have the inability to breathe independently and have been on a ventilator for a prolonged time. So that could be because of advanced critical illness with respiratory failure. It could also be because of a high spinal cord injury. So most patients who have a severe spinal cord injury at C5 or higher will require mechanical ventilation for some period of time. And most patients with the spinal cord injury at the 3rd cervical vertebra or higher will require prolonged mechanical ventilation because of injury to the phrenic nerve. Another indication for tracheotomy is upper airway obstruction. So that could be a cancerous tumor, it could be laryngeal edema or other edema in the upper airway, or it could be because they've had a reconstruction for cancer after a tumor was ablated. So for example, a free flap. Some patients receive tracheotomies for obstructive sleep apnea. That is far from the first line treatment, but it is occasionally used in that population. Certainly trauma is a common reason, other than spinal cord injury, severe mouth or neck injuries, burns, gunshot wounds to the face, anything that interferes with the upper aerodigestive tract. And finally, neurological conditions that cause the vocal folds to be paralyzed in the median position. So they're adducted together and are completely occluding the upper airway. Those patients may require an emergent tracheotomy to breathe. This being a very heterogeneous patient population, I would like us to start thinking already at this point in the presentation about how dysphagia may or may not be present in these different patient populations, not necessarily due to the tracheotomy, but because of these conditions that prompted the tracheotomy in the first place. Here's a diagram just for anyone who may be less familiar with the tracheotomy, just to review how it works. So here's a view of the patient externally. Here you can see the tube sitting in the trachea. So in this diagram, this is the epiglottis. Here are the vocal folds. This is the thyroid cartilage and the cricoid cartilage. In this diagram, the cuff on the tracheostomy tube is inflated. So all of this patient's air is going in and out of the tube, and the upper airway is excluded. So all of these structures here, the larynx, the pharynx, the oral, and the nasal cavity, are no longer part of the airway in a patient with a tracheostomy with an inflated cuff. Any questions about that before I move on? Okay. There are two primary procedures to create a tracheotomy. The most common one in my setting these days is a percutaneous dilational trach. So this can be done at the bedside in an ICU patient. The patient does not have to be fully sedated. They could be awake with only local anesthesia. The physician will create a small opening in the neck at the level just below the cricoid cartilage above the first tracheal ring, and they will use these progressively sized dilators to dilate the opening until the tracheostomy tube can be safely inserted. These patients tend to have fewer complications from the tracheotomy itself, but they also tend to be less complicated patients in the first place in some ways, at least as far as their upper airway anatomy. The other procedure is a surgical tracheotomy, which I'll show some pictures of at the end. These patients are fully sedated and an incision is created in the neck. These tracheostomies, you'll see patients where the tracheostomy sits a little bit lower on these patients because they actually make an incision in the proximal tracheal rings for this placement. And there are different methods of both dilational tracheostomies and surgical tracheostomies. That's just a basic overview of the two main types. This is a typical tracheostomy tube. So you have a cuff that has a pilot balloon attached to it that helps the user gauge how much air is in the cuff. This is the flange that sits on the neck, and then this part is exposed, and this part, the distal aspect of the tube, sits in the patient's airway. This is a plug that can be used to occlude the tracheostomy tube at the appropriate stage. Most tracheostomies that I encounter have disposable intercannulas, but there are reusable intercannulas that can be cleaned and replaced. The purpose of the intercannula is to clear secretions and mucus plugs and keep the tracheostomy tube clean. And this is an obturator that is used for emergencies or if the tracheostomy tube needs to be exchanged, and it should be kept at bedside for all patients with new tracheostomies as a best practice from a safety standpoint. Two main categories of tracheostomy tubes are those with cuffs and those without cuffs. Patients who require mechanical ventilation must have a cuffed trach in order for the ventilator to be able to deliver the complete volume ventilation to the airway. Patients who don't require mechanical ventilation and are not expected to have an upcoming procedure or expected to need mechanical ventilation can be transitioned to a cuffless tracheostomy tube, and we'll talk about pros and cons of the cuff later in the presentation. Here are a few other less common types of tracheostomy tubes that you might encounter. This is a metal tracheostomy tube and a metal obturator that are used in more chronic long-term patients. This is a fenestrated tracheostomy tube. The word fenestration means like a window. So there's these openings in the tube that allow airflow from the trach into the upper airway. These are not used as commonly as they were in the past. The reason being that they've been shown to cause granulation tissue in the airway, where the mucosal membrane is irritated by these little fenestrations and it wants to heal. I've unfortunately witnessed some very painful and bloody trach exchanges in patients who had granulation tissue grow onto these fenestrations. They're occasionally still used, but have generally fallen out of favor, at least in the settings in which I practice, because of that concern. This is a fairly sophisticated and expensive tracheostomy tube. It's flexible. The flange is adjustable, so you can adjust the length of both the distal and the proximal tube. And this is in fact a cuff trach, but you can barely see the cuff on the end of the tube because it's what's called a tight shaft cuff. So when the cuff is fully deflated, there's no residual volume of the balloon in the patient's airway. It's cinched up tight around the tube. These are two types of cuff trachs for patients who require extra length for whatever reason. So this one is a proximal extra long for a patient who perhaps has a lot of adipose tissue or swelling or other anatomical issue in the neck. And this one is a distal extra long. I've sometimes seen these used in really tall patients, but typically it's to bypass an injury or tracheal stenosis or some other anatomical abnormality in the proximal trachea. And here's just examples of airflow. So cuff fully inflated, the air only goes in and out of the cuff. Uncuffed or with the cuff deflated, air primarily goes in and out of the tracheostomy tube, but the patient can also pass air through their vocal folds into their mouth and nose. And this is that fenestrated tracheostomy tube where more airflow can pass through the tracheostomy tube itself and into the mouth and nose. But again, I really don't recommend that type. And this is just a diagram showing how the tracheostomy tube can be used to access the airway to suction. Most commonly secretions, but occasionally blood or aspirate or vomit or some other substance can be suctioned from the airway. There are a few different types of suction, but this is what's pictured here is a very common type of bedside suction catheter. So that's a part one, just a overview of tracheostomy tubes. Are there any questions on that part? I'm not sure everyone's role, and I apologize if some of you who are physicians already know all of that.
It was a good overview.
Great.
No questions in the chat.
Okay, great. I'll keep going. Thank you. So now part two, I'm going to review a sampling of the literature about tracheostomy and dysphagia. There are many controversial things I'm going to discuss in this next section and some things that have been studied to death, but I tried to summarize the literature and we'll move through this promptly. So, does a tracheostomy cause dysphagia? That word cause being very important. It's a more controversial question than you might think. I was trained that yes, a tracheostomy does cause dysphagia, and patients with tracheostomies have dysphagia, have aspiration, more than their non-tracheostomized counterparts. That's actually a pretty complicated question, as it turns out. The literature varies widely as far as what percentage of patients with a tracheostomy aspirate. And that goes back again to the fact that this is a heterogeneous patient population. I would say that these numbers vary so widely that the answer is that no one really knows. But we do know that many patients with a tracheostomy have dysphagia and are at risk for aspiration. One thing that's very consistent in the literature is of patients with a tracheostomy who do aspirate, the percentage of the time that that aspiration is silent is high. It's almost 4 out of 5. So the late Steve Leader, who did a ton of research, he did a lot of research on tracheostomy and dysphagia, found that in a group of acute care patients, about a third of them aspirated. And of the ones who did aspirate, 82% of those aspirated silently. This number has almost been replicated in other studies. So Bergel and colleagues in 2018 found that 83% of the tracheostomy patients in their cohort who aspirated did so silently. And Marvin and Susan Thibault in 2021, again recently, found about 81% of the patients in their cohort who aspirated did so silently. So this number, percentage of patients with tracheostomy who aspirate, is all over the place in the literature. But this number, that 4 out of 5 of those aspirators are silent aspirators, is very consistent. We can't make the mistake of taking that to mean that a tracheostomy itself causes dysphagia or causes aspiration. The reason for that is the coexistence of dysphagia and tracheostomy in critically ill patients, or neurological issues, or patients with head and neck cancer or anatomical changes to the upper airway that prompted the trach. Additionally, many individuals who start off being orally intubated, who were converted to a tracheostomy, were orally intubated for a prolonged period of time, days to weeks. And the oral intubation itself causes dysphagia due to damage to the larynx. So, regardless of the reason, we do know that these patients often have dysphagia and often have aspiration. It may or may not be because of the trach itself. It may be because of their underlying, general medical status, their conditions that cause them to require this tracheostomy in the first place. Again, Steve Leader and his colleague, a medical doctor, Dr. Ross, looked at a group of patients in 2000. They did FEEs before and after the tracheotomy population on 20 critically ill patients. And again, the caveat there, this is a fairly small sample size because you can't design a randomized controlled trial where you just give patients a tracheostomy and see if they aspirate. That doesn't exist. So it's hard to find large, well-powered studies on this topic. But they found a group of patients over a course of about 3 years, I think between 1997 and 2000, who they were able to do a FEES on before and after their tracheotomy procedure, but before they were decannulated. And they found that 19 of 20 of those subjects, so 95%, had the same aspiration status before and after the tracheotomy. And they concluded that there was no causal relationship between the tracheotomy and aspiration. So there were 12 subjects who aspirated before the tracheotomy, who also aspirated on the FEES after. And there were 7 of 8 patients, who did not aspirate before the tracheotomy and also did not aspirate after. They did have that one subject, I would point out, who aspirated after they got the tracheotomy, but not before. And while they conclude that's no causal relationship, to me, if I see 20 patients within tracheotomy and one of them is aspirating because of it, I do want to know that about that one patient. So take that with a grain of salt. Leader and colleagues also replicated this study. I think in 2010, they came out with another version with a different patient cohort showing almost the same thing. And Dr. Leader was always very blunt in his article titles and in his wording, and he wrote something like confirming no causal relationship between tracheostomy and aspiration in his follow-up article. I have all that in my references. So, does a tracheostomy cause dysphagia? The take-home messages, I would say, for clinical practice is that this topic really does not lend itself to randomized controlled trials. So we're looking primarily at retrospective studies and observational studies. We're using our own clinical practice and our clinical judgment. Whether there's a causal relationship between tracheotomy and aspiration remains debated. I came across a few attempts at meta-analysis of this topic, and they looked at many articles and concluded that the patient populations and the methodologies were so varied that it was not possible to do a true statistical meta-analysis. So this topic remains debated. But regardless, as a clinician, we know that tracheostomy is highly associated with dysphagia, and it's likely multifactorial. It could be the trach itself, but it's almost certainly impacted by the conditions that caused the tracheostomy to be required in the first place. So again, prolonged intubation, severely deconditioned, critically ill patients, patients with a compromised upper airway due to cancer or to some other factor, patients with edema in the upper airway, laryngeal problems, burns, trauma. These are all patients who aspirate regardless of whether they have, or who are at risk for aspiration and dysphagia, regardless of whether they have a tracheostomy. And this very important topic, this last point, I think, is that of patients with tracheostomy who aspirate, we know that they often do so silently. So about 4 out of 5. So there are a few hypothesized causes of dysphagia related to tracheostomy other than the underlying condition. And I'm going to go through a few of those. But again, I want to note that there's some lack of consensus around some of these hypotheses. The first one that I want to talk about is laryngeal elevation. What I was taught in school when I was studying dysphagia was that a tracheostomy tube tethers the larynx and it impedes the normal high laryngeal elevation and excursion. Dr. Ding and Dr. Logeman, who is a famous dysphagia practitioner who pioneered FEES, did a number of studies on this, the biggest one in 2005, and they found that an inflated cuff could limit high laryngeal elevation and excursion. Amatiu and colleagues looked at a cohort of patients that they randomized cuff pressures to. So that balloon on the distal end of the trachea, they said that it would be 10, 20, 30, 40, 50, or 60 millimeters of mercury, I believe was the measure they used. And they found that increasing cuff pressures could had a linear relationship to diminished high laryngeal elevation and excursion. However, there were some studies, again, famously Dr. Leader, who did not replicate that, although they assessed patients with normal swallowing. And they took patients who were non-dysphagic, but who had a tracheostomy and looked at their cuff pressures, and they did not find any changes to laryngeal elevation or excursion. There were also some very interesting studies that looked at swallowing mechanics in the same patient immediately before they were decannulated, so before their trach was removed, and immediately after their trach was removed. And those studies found very mixed results. So I feel comfortable saying that we don't know whether a tracheostomy tube limits high laryngeal elevation and excursion, but it may in some patients, particularly if those patients require an inflated cuff. A second possible cause of dysphagia related to tracheostomy is lack of subglottic air pressure. Again, there's some lack of consensus on this topic. Gross and colleagues in 2003 compared the same patients with a speaking valve versus an open tracheostomy tube. I'll talk about the speaking valve more in a minute. I'm not sure if you all are using these in your practice. The brand that we use most commonly here is Passimir valve. It's a bias closed one-way valve that can be applied to the end of the tracheostomy for patients who are able to tolerate cough deflation. And it enables them to breathe in through the tracheostomy tube, but when they breathe out, the valve closes and they breathe out through their mouth and their upper airway. So Gross and colleagues found that when a speaking valve was used versus just an open trach, The patients had better scores on the penetration aspiration scale, and they had a faster transit time of the bolus when they swallowed. There are multiple studies suggesting that a speaking valve or a cap reduces aspiration, and there's also a few studies that did not find that. So again, I think this comes down to a very patient-specific situation for us as clinicians, that we want to look at the individual patient in front of us and evaluate whether they benefit from a one-way valve or a cap on their tracheostomy to restore their subglottic air pressure, and therefore their sensation to their upper airway and their ability to expel aspirated material from the airway. May I ask the group a question? Do you all use speaking valves routinely in patients with tracheostomy at your hospitals?
No, normally we don't use it.
Okay, thank you. That helps me know how much time to spend on that topic later in the presentation. Thank you.
Maybe they should, Melissa.
Maybe, yes. I found them to be very helpful in this patient population for both communication and for swallowing and secretion management. We'll talk about that more later in the presentation. So another cause of dysphagia potentially related to the presence of a tracheostomy tube is incoordination of breathing and swallowing. So our typical pattern is to swallow mid-exhale, which helps expel any aspirated or penetrated material from the airway during the swallow. In a patient with a tracheostomy, particularly with an open tube or connected to mechanical ventilation or with the cuff inflated, there's a lack of expiratory flow into the upper airway after the swallow. So their ability to expel aspirated material is impaired. Patients with respiratory compromise, so patients who have a trach for respiratory failure, may already have breath swallow incoordination. And mechanical ventilation will really depend on the mode, on the ventilator settings. So in some modes like pressure control, the patient is not able to time their own breaths. The ventilator is doing that for them. So it's very difficult for the patient to coordinate their swallowing and when they take a breath. There are other ventilation modes like pressure support and a few other modes where the patient has control over their respiratory rate. And those patients can be better able to coordinate their breathing and their swallowing. Reduced cough effectiveness is another possible cause of dysphagia in this population. So because they are getting most of their airflow in and out of the trach rather than in and out of the upper airway, their cough isn't effective. They're not as able to effectively mobilize secretions. So these patients often have poor secretion management. Their mouth is full of secretions. There's secretions coming out the trach. They're often making a lot of extra secretions in a new trach because of mucosal irritation. And these may be patients, again, who are critically ill, weak, deconditioned, so those long ICU patients who have critical illness myopathy, or they may have a paralyzed diaphragm that impairs their ability to mount a cough. So again, factors that may or may not be related to the trach itself that increase the risk of dysphagia and aspiration in this patient population. I wanted to briefly talk about cuff inflation or deflation. There's a very common notion out there among nurses, among respiratory therapists, and among many physicians, even some lung pulmonologists who commonly work with this population, that inflating the tracheostomy cuff prevents aspiration. And that's just not quite right. The definition of aspiration is that material, so the person's secretions, food or liquid that they've tried to swallow, or their gastric contents, are below the plane of the glottis, so below the level of the vocal folds. So here's your vocal folds, and the cuff is down here. So any material that's sitting on top of this cuff has already been aspirated. It's already below the vocal folds. At best, the cuff can delay that aspirated material dripping further down into the lower airways. But the cuff doesn't form an airtight seal against the tracheal wall, or it shouldn't. An overinflated cuff can damage the tracheal wall over time. So material is able to pass around the cuff into the lower airways and into the lungs. That being said, I want to have the caveat to the caveat that there may be some advantages to cuff inflation preventing aspiration in certain cases. Patients who have really copious secretions, the cuff can give you time to suction those secretions before they fall down into the lower airway. And I always, in my clinical practice, recommend cuff inflation for patients who are vomiting, for patients who are having nausea and emesis. Keeping that cuff inflated gives you a little bit of time, if you notice that patient is vomiting, to get in there with an oral suction device and suction their upper airway after they vomit to try to prevent that, very caustic, inflammatory material from leaking into the airways. So, bottom line, an inflated cuff does not really prevent aspiration, but that's a common myth that I'm sure all of us have heard or will hear at some point working with this population. Deflating the cuff is an important part of progression for patients with tracheostomy. So patients who require mechanical ventilation must have the cuff inflated most of the time. There's one little caveat there about speaking valves. Typically, patients on mechanical ventilation need the cuff inflated. However, as soon as patients are able to be weaned from mechanical ventilation, deflating the cuff is good. There are, again, a number of studies that show that cuff inflation versus cuff deflation in the same patient increases the risk of aspiration. There's also more silent aspiration when the cuff is inflated. The most likely causes for that are impaired sensation in the upper airways. If the patient's not getting airflow, they're not able to feel that there's penetrated material in the larynx. Also, their cough reflex is impaired, like we talked about earlier. Again, Dr. Logeman did a retrospective study that I believe was 600 and something patients. They found that silent aspiration was 22.6% of their cuff inflated group versus, actually I think that's supposed to just say aspiration rate instead of silent aspiration, I apologize, versus 7.2% for individuals with a deflated cough. And Hernandez and colleagues did a randomized controlled study of critically ill patients. And the cuff inflated group had higher rates of respiratory infection, including ventilator-associated pneumonia, compared to the people with deflated cuffs. And again, you could say, oh, well, patients who were able to have a deflated cuff are healthier, but this was a trial where they were able to do randomized controls. So I think that's pretty good information. The other thing that we see in our clinical practice is that the cuff, especially if it's overinflated and the cuff pressures are really high, over time causes irritation to the tracheal wall. It can cause granulation tissue, causes decreased sensation. So cuff down is better. As soon as we can take that cuff down, we want to be advocating for that. Also, some patients can talk with the cuff down even without a speaking valve because they're able to move air around the trach. And I just cannot overstate how meaningful it is for these patients who have had a tracheostomy for perhaps a long period of time or who have been on mechanical ventilation to be able to communicate with their loved ones, their families, and to communicate medical information with the care team. So cuff down is good. I'm primarily going to talk about patients with a tracheostomy who are not on mechanical ventilation, but I did briefly want to discuss this population. So patients who are on prolonged mechanical ventilation who have been converted from oral tracheal intubation to a tracheostomy tube, can they eat? The answer is sometimes. And again, it's highly dependent on patient factors. The ventilator modes matter. We want to encourage and favor modes where patients control their own respiratory rate if able to help them coordinate breathing and swallowing. And as clinicians, when we're evaluating this, we want to consider the reason that they're requiring that ventilation in the first place. So, two examples here. A patient on mechanical ventilation following a prolonged critical illness, pneumonia, and respiratory failure, who now has a trach, who's wanting to eat and drink while they're still hooked up to the ventilator, versus a previously healthy, let's say young adult, cognitively intact patient who's on mechanical ventilation for a high spinal cord injury. I know which one of those patients I would be more comfortable feeding or doing a swallowing assessment on. Both of those patients would benefit from a thorough instrumental evaluation. But one of them, that previously healthy patient, is much more likely to be successful, and I would have a much lower threshold for getting started with the process of evaluating that patient's swallowing compared to the fragile, critically ill patient. So part 3, I'm going to dive into that topic a little bit more and talk about evaluation and treatment of this patient population. Any questions about the previous part before I move on?
No questions in the chat.
Great, we'll keep going. Okay, thank you. Evaluating dysphagia in this population really requires a holistic approach. So we want to consider the underlying etiology that required the tracheotomy. We want to consider the patient's age. Several studies showed increased risk of aspiration over 70 years of age, some over 65. These patients have decreased functional reserve. So an older patient, we would be more suspicious of dysphagia. We want to consider their underlying medical complexity, so their respiratory status, their ability to ambulate, their ability to feed themselves and do their own oral care. And we want to consider how fragile their lungs are. Are these patients able to tolerate aspiration, trace amounts of aspiration? So it's looking at the whole picture of the patient. Of course, ventilator dependence or not is an important factor. And we want to look at the type, size, and the status of that tracheostomy tube. So is it a number 6? Is it a number 8? Is it cuffed, cuffless, fenestrated? Have they already been downsized to a small number 4 metal trach? And we want to look at the time since the tracheotomy was done. Typically at my facility that I recently left, the physicians who perform tracheostomies like to wait about 24 hours before considering a dysphagia evaluation, just to give the patient time to heal in the immediate area of the tracheotomy procedure. And status of the tracheotomy tube, meaning are they able to tolerate deflation of the cuff? Are they able to tolerate placement of a one-way speaking valve? Are they able to tolerate using their finger to occlude the tube to talk? All things that we want to look at in our evaluation. The patient's respiratory rate, their cognition, their mentation. There is one thing that I wanted to note here. A lot of facilities are using a 3-ounce water swallow screen to figure out whether patients need further evaluation of dysphagia. And this is the one patient population pretty much that screen is not at all appropriate for. Dr. Leader, Dr. Suter, and Dr. Green, who developed the L-Swallow protocol, have been adamant that because of the high risk for silent aspiration, again, that almost 4 out of 5 statistic we saw earlier, patients with a tracheotomy are not appropriate for a 3-ounce water swallow screen, if you all are using that at all. So the bottom line, the take-home message from this slide is that just like any other patient with dysphagia, we want to look at the whole picture of the patient, and we want to gather some specific information about their tracheostomy. The clinical bedside evaluation has some utility in this population, but it's different than other groups. Again, that statistic about 4 out of 5 patients who aspirate with the tracheostomy do so silently means that bedside PO trials alone are insufficient to detect aspiration in this population. The clinical bedside evaluation does have advantages, though, for this group. It's an excellent opportunity for patient education. It's an opportunity for you as the clinician who's treating their dysphagia, whether you're a physician interested in this topic or an occupational therapist or another type of therapist, to come in and introduce your role, explain to them the trajectory of care with regard to swallowing and their tracheostomy. It's a great opportunity for patient education. Very, very often, when I go to see patients who have had a new tracheostomy and we've received a referral for a dysphagia evaluation, that patient has been in bed since they had their tracheostomy and they have not seen it. They know that they have a thing in their neck, but they don't know what it looks like. They don't know how it works. So I usually bring a small mirror with me that I can set up on the patient's table. Some patients are not quite ready to see it or they're a little bit alarmed. So I always ask them, would you like to see this today? Usually they say yes. And if they do, I set the mirror up on the tray table. And I usually bring a diagram, like one of the ones that I showed earlier in this presentation, to try to explain how the trach works. The patient may or may not be in a mental state to take all of that in at this point, but the families are usually very interested if the patient is not. The clinical bedside evaluation is also a great time to do your oral motor exam, to look at the patient's respiratory rate, their oxygen saturation, and their overall endurance. And by endurance, I mean, does this patient get fatigued, have increased respiratory rate or heart rate or oxygen desaturation just from sitting up and trying to communicate with you? If so, that may be a sign that they're not quite ready for oral feeding. If they are too deconditioned to even sit up, they're probably not going to be able to get through a meal. While you're there doing your clinical bedside evaluation, you can talk to the nurse or the respiratory therapist and assess that patient's suctioning needs or their secretion characteristics. Or if this is an outpatient who's coming in to see you, you can ask them how often they're suctioning themselves. It's an opportunity to encourage oral care and encourage the patients to get up and move to help clear out their lungs. So aspiration pneumonia is about more than just dysphagia, right? We know we want to support oral care and movement in this patient population to help clear out their lungs and ensure that if food or drink is going down the wrong way or secretions are going down the wrong way, it's coming from a nice clean mouth and not taking pathogenic bacteria from the mouth into the airway. So your clinical bedside evaluation is very helpful for everything except for the PO trials. One more thing I wanted to say about that topic. This presentation is about dysphagia, but often meeting these patients for the first time is an opportunity to get them set up with some communication tools. So paper and pen on a clipboard or a whiteboard or a board with picture or words where they can point to things that they need or want. Not strictly about dysphagia, but it goes a long way to promoting care of the patient and the patient's independence. I'd like to talk about the modified Evans Blue Dye test. This is a controversial subject. It was used more earlier in my career when I began practicing, and it's kind of fallen out of favor. What I want to emphasize is that it's a screening tool. It's not a diagnostic examination. I do feel that it has some utility in clinical practice. It's easy, it's economical, it's well tolerated, but you have to know how to use it as a tool in your toolbox. The modified Evans Blue Dye test has very poor sensitivity, but very good specificity, meaning that it's not very good at detecting aspiration. But when it does detect aspiration, you can be pretty confident that that patient is aspirating. So I'll talk about what this is. The original Evans Blue Dye test, as described by a Dr. Cameron in the literature back in the 60s, involved administering a dropper of methylene blue, which is it's used as a drug. I think it's an antidote to poisoning. I'm not sure what else it does, but it's a bright blue dye. And Cameron advocated putting it in saline and putting it in a dropper on the tongue every 4 hours for 48 hours. And then after the dropper was administered on the tongue, you would suction the patient through the trach, and you would hold up the suction tubing up to the light and examine it and look for any blue dye in the suction. So things that go in the mouth should not end up in the airway in a patient who's not aspirating. And Evans reasons that if you're finding blue dye from the mouth in the airway, you know that there's communication between the air digestive tract and the lower airways. And therefore, that patient, the way he wrote it, is not a candidate for oral feeding. The modified Evans blue dye test involves using your normal food and drink trials that you would use for a swallow evaluation. So commonly applesauce or some sort of puree, a liquid, a solid, and putting drops of the blue food coloring in the PO trials. And there are various protocols described in the literature. Belafsky and colleagues did it 3 times. So they would do it 30 minutes and 60 minutes after the first test. They reported pretty good sensitivity. There are a lot of different protocols written about how long you wait to suction, whether you give one food texture at a time versus multiple. But the general principle is the same. You put dye in the mouth, you suction, and you hope that it's not in the airway. So here's an example of a patient who's had either blue food dye or methylene blue in their mouth, and it's coming out in their tracheal secretions. Essentially proof that they're aspirating. This topic has been just researched to death, and the literature is all over the place. Bichette and colleagues did a meta-analysis and found widely varying sensitivity estimates, but the study showed pretty good specificity. So generally, this is not going to detect really trace amounts of aspiration, but it might detect gross amounts of aspiration. It has a low negative predictive value, so the ability to predict correctly the absence of aspiration. So if you give the modified Evans blue dye test to a patient and they do not have return of the blue dye in their tracheal secretions, you don't know for sure that they're not aspirating, but that patient is probably a good candidate to go on and have a further instrumental swallowing evaluation, like a FEES or a video swallow. What the modified Evans blue dye test does have is a high positive predictive value, so the ability to correctly predict the presence of aspiration. So patients who have a positive modified Evans blue dye test, dye in their tracheal secretions, definitely aspirated. And perhaps those patients, because you know they're aspirating, don't need additional procedures. They don't need a FEES or any other type of swallow study yet. A small caveat there is that you could still try a FEES to experiment with bolus characteristics or with compensatory strategies in appropriate patients. So you could use different size sips on the FEES, you could use thickened liquids, you could try compensatory maneuvers like a chin tuck or a head turn or a hard swallow in appropriate patients. But you do know that those patients are at least at risk for aspiration, or that they may need some additional measures to prevent aspiration. So in summary, lack of blue dye in the airway cannot rule out aspiration, but the presence of blue dye in tracheal secretions confirms aspiration. Are there any questions about the modified Evans blue dye test before I move on to other assessment tools?
Wondering, do you do the blue dye test in Thailand? Olay?
Yes, excuse me. Yes, we try to use the Buddha test in tracheostomy case. And I have a question. Should we repeat the Buddha test after the first time that we test the Buddha?
Excellent question. I think you could repeat it. If you found that the patient passed the test, meaning they did not have any return of dye in their tracheal secretions, that patient probably doesn't need to have it repeated. They could go on to have a FEES or some other method of confirming the absence of aspiration. If they do have return of dye in their tracheal secretions, like they failed the test, I would probably wait a few days and try it again, or wait until they've had a change in their clinical status. So they're more alert, or they're breathing better, or their cough strength seems to have improved, some factor like that. And then I might try it again. If they still fail, I would probably wait longer. But you're waiting for them to just pass that test so that you can move on to another method of examination. I know that FEES is not possible everywhere and in every situation, but the best practice in the literature is that a patient who passes the blue tie test should go on to have another study like a FEES done to confirm the absence of aspiration. Does that answer the question? Great, thank you. And you all are doing FEES at a lot of your facilities, right? I think I remember that from last time we spoke.
Yes, and they were trained by Susan Langmore.
Oh, that's fantastic.
I know.
That's wonderful. I also attended Dr. Langmore's FEES course in Boston when I learned FEES. So she's a fabulous teacher. I love that we have that in common. While doing blue dye, do we need to deflate the cuff, Dr. Shushila? That's a great question. Not necessarily. Not necessarily. If the cuff is inflated, I would probably wait a little bit longer to do the suction, or I might do it right after and then do it again in 15 minutes, because the cuff can delay the material passing around the cuff into the lower airway where you suction. If the patient is able to tolerate having the cuff deflated, I think that might make the exam more reliable, but it's not strictly necessary, no. That's a fantastic question. Anything else on that topic? So instrumental exams are widely considered a necessity in the setting of tracheostomy. And to just put a fine point on this, I included a couple of quotations from an article from Dr. Sasaki and the late Dr. Stephen Leader, who I mentioned earlier. This was not a research article, but it was sort of a letter to the editor that they submitted to the journal Dysphagia in 2016. This was shortly before Dr. Leader's passing. It was titled Comments on Selected Recent Dysphagia Literature. And they wrote in this opinion piece, "We are of the strong opinion that all patients needing a tracheotomy tube require instrumental testing. Only endoscopy or video fluoroscopy can examine the upper airway, evaluate pharyngeal and laryngeal functioning, determine aspiration status, diagnose dysphagia, and recommend an appropriate oral diet." And I just wanted to include those quotations to tell you that it's not me saying you have to do FEES on every one of these patients, but that's an opinion out there by people who were top researchers and leaders on this topic. Does every single patient who gets a tracheotomy at the facility where I work get a FEES? No, they don't. Certainly not, a previously healthy patient who's getting a tracheostomy for sleep apnea or something like that. But most patients who have some upper airway complication or critical illness and have a tracheotomy could benefit from a FEES or a video fluoroscopic swallow study. Excuse me. I want to talk about the pros and cons of video fluoroscopy and FEES in people with tracheostomy. Video fluoroscopy can allow assessment of the esophageal phase, and it may be better tolerated by some patients. And if there's a concern for gastric or gastroesophageal reflux that's coming out of the esophagus and getting into the airway, a video fluoroscopy would be a better way to evaluate that. However, it requires patients to go off-site usually, to the radiology suite, which may not be appropriate in this tenuous patient population. And importantly, it does not allow visualization of secretions. Fees, on the other hand, can be done at bedside, is more economical. It allows visualization of the secretions, vocal fold movement, and the upper airway status. So there's pros and cons to both types of exams. But the fees is something that we often like to use in this patient population where I work. Here's an example, an image from a fees of a patient who has copious secretions. So when you're assessing the tracheostomized patient, if you're seeing copious secretions like that, those pooled secretions are indicative of aspiration risk. So there's Dr. Langmore. Dr. Langmore and some of her colleagues looked at this and commented on pooled secretions increasing risk of aspiration. So in the case of copious secretions, you might consider deferring the rest of the exam or giving only ice chips, and then there's minimal risk to the patient. All you've done is got in there and taken a look. Another advantage to fees is that it allows you ample time to try different conditions in this patient population. And what I mean by different conditions is you can try PO trials with the cup inflated. Then you can try PO trials with the cup deflated. You can try PO trials with the patient using their finger to occlude the tracheostomy tube while they swallow. You can try putting a speaking valve, if appropriate, on. So you can do as much as you want. There's no time limit other than how much time you have and how much the patient can tolerate, compared to video fluoroscopy, where you usually have a maximum of 5 minutes of fluoro time. So many advantages to fees in this group. Treatment techniques, it's really quite similar to other adults with dysphagia, with the exception of the first bullet point on this list. So back to the causes that we talked about in part 2. Reduction in subglottic air pressure in patients with an open trach can contribute to dysphagia. So one thing that you can do for treatment is to restore that airflow through the upper airway via either having patients occlude the trach with a clean finger when they swallow, or use of a one-way speaking valve, or in patients who are appropriate or ready, working with the medical team to find out if they're ready to have their trach capped. In this patient population, you can do swallow exercises just like you do with any other patient population with dysphagia. And again, you want to target the physiological impairments that you've identified on your swallow study. So if you did a FEES and you saw that they had a decreased laryngeal vestibule closure, or you saw that their pharyngeal constriction was reduced, or that they had a reduced base of tongue retraction, you would want to select exercises and intensity of exercises to target those specific physiological concerns. Similarly, you can use swallow compensatory strategies, just like other patients with dysphagia. And again, you want to trial those during your FEES and implement the ones that are effective for that particular patient, whether it's trying to hold their breath while they swallow, putting their chin down, a head turn, a hard swallow. Maybe they swallow and then they cough or clear their throat to expel aspirated material and they re-swallow. So those second and third bullet points, the swallow exercises and the swallow compensatory strategies, are just like other adults with dysphagia. The final point I want to make, there's a turn of phrase or an expression that I've heard some of my physician colleagues use, that some patients just require tincture of time. These are often patients who are critically ill and their recovery process can be slow. And sometimes you just have to wait. And that's hard when you haven't been able to eat or drink for days or weeks. That's hard for patients to accept, but sometimes what they do need is more time. And patient education and counseling is key in that situation. And that's another advantage to FEES. You can record the images and let patients see, hey, here's what happened when you tried to swallow. Here's where the material should have gone, and here's where it went into your airway. That's an important aspect of counseling. So the speaking valves that I mentioned earlier, this is a picture of one type of speaking valve. This is a passy mirror speaking valve, and I think this is the number 1. We call it the purple valve at my facility. So it's a one-way valve that goes onto the end of the tracheostomy tube. You can't quite see it, but there's a thin silicone membrane in there. And when the patient breathes in, that membrane opens and they breathe in through the trach. When they go to breathe out, the membrane closes and it forces the patient to breathe around the trach and expel the air through their upper airway, so their mouth and their nose. A very important caveat to this is that the speaking valve cannot be used if the cuff is inflated. I see a question pop up, but it disappeared. Connie, could you read me the question from the chat?
You know that the tracheostomy tube patient is ready to deflate cuff.
That's an excellent question. Typically what we're looking for is that the patient is not having nausea or vomiting and that they are able to manage their own secretions. So they're not having a lot of pooled secretions in the oral cavity, and when they're being suctioned tracheally, you're not getting a lot of secretions. We also like it when those secretions are thin and clear. We don't like it when those secretions are thick, tenacious, sticky. So those are the main criteria: is no nausea and vomiting and adequate secretion management. And if the patient meets those criteria, you can trial cuff deflation with a physician or nurse or respiratory therapist standing by to monitor the patient's heart rate, respiratory rate, and oxygen saturation to make sure that they're able to tolerate that cuff deflation. It's a great question. So this valve, typically how we use this with patients is we ensure that they are generally stable, hemodynamically and cognitively. We try cuff deflation and make sure that they're able to tolerate it. And then we would place this valve for a brief period of time. Or we may start by doing some finger occlusion first to see if they're able to move air up through their upper airway. We want to know, is the patient able to either phonate,
is the
say
patient able
ah,
to either phonate,
say ah, or move air by blowing out through their mouth or nose? I apologize. There's suddenly a little bit of feedback. Does anyone else hear that?
Mute. Try again. I think I muted them.
Okay. Thank you. I'm sorry about that. I suddenly could hear my own voice in my ears and it was disorienting. Thank you very much. Excuse me. So we would try the valve or finger occlusion for a brief period of time to make sure that the patient has a patent upper airway. So they're able to phonate, say ah, or we might have them blow on a tissue to see if they can blow to move air out through their mouth or their nose. And again, we would monitor their respiratory rate, their oxygen saturation, their heart rate. We would look to see if they're breathing comfortably or if they're having like a lot of clavicular breathing. And we would also take the valve off periodically to make sure that they're not stacking air behind the valve. If they are accumulating air behind the valve, that's a sign that they're not able to fully exhale and that they're at risk for hypercarbia. I could do a whole presentation on using speaking valves, so I won't spend too much time on this topic. The most Shiley makes valves, but Passy Muir is the most common brand of these types of valves, and they have a lot of free continuing education modules on their website, and they also have clinical educators who are, probably eager to speak with anyone who's interested in using this product. I don't work for them. I'm not affiliated with them in any way, but I love these one-way speaking valves in patients with tracheostomy, and would highly encourage anyone who frequently works with tracheostomized patients to look into this more. And of course, I'd be happy to talk with you about it more in the future if you'd ever like to have me back. It's a whole side topic that I won't go down, but The speaking valve, many studies suggest that it does reduce aspiration because it restores some airflow to the upper airway. It improves subglottic pressure so patients are able to cough and clear material out of the airway, and it enables them often to communicate, which is just priceless. But it's not appropriate for every patient. The most important thing is that the cuff has to be deflated. Best practice during instrumental evaluation of swallowing is to evaluate patients under both conditions. Sorry, I see a request to annotate the shared content. Okay. Best practice is to evaluate patients under both conditions, so with an open tracheostomy and with a speaking valve if they're able to tolerate it. And the reason we do that, there's a temptation like, oh, my patient is doing really well with the speaking valve, so I'm going to go do the fees and I'm just going to do it with the speaking valve on because that makes her swallowing better usually. But sometimes what you run into is you do a fees or a swallow study of some sort with the speaking valve on, and you say, oh, this patient isn't aspirating these consistencies, they can eat and drink these IDDSI levels. But then later on, the patient says, oh, well, I don't want to wear the speaking valve, or the speaking valve makes them feel a little short of breath, or there's some other reason why they can't wear it. And then you don't know if that patient can safely eat or drink. So when I'm doing instrumental evaluations in patients who are tolerating a speaking valve or a cap, I always try to do some trials under both conditions, the valve on and the valve off. And then you have done one study that's a comprehensive reference of all the conditions under which this patient can safely eat or drink. I hope that makes sense. Any questions about the speaking valves while we're on this topic and have the picture here? Connie, I thought I may have seen another question pop up in the chat. It briefly pops up on my screen and then it disappears.
The question was, does the shaker exercise appropriate for trach patients?
Maybe is the answer. The Shakir exercise is the one where you have the patient lie flat on the bed and then they raise their head up to look at their toes. And I don't remember the exact contraindications in the literature, but I know one of them is that the patient has to be stable from a cardiac standpoint, because it is sort of a, there can be like a Valsalva maneuver that occurs during the procedure. I don't typically use this exercise on this patient population because they're usually pretty sick. And most patients who have severe respiratory illness also have some degree of cardiac compromise. But there could be some tracheostomized patients who could use that exercise. I typically, just because it's a challenging exercise for patients and because there are some contraindications, I don't usually use the Shakir exercise in this group. One that I do like that has come out more recently that's similar, that exercises some of the same muscle groups as the Shakir exercise, is the chin tuck against resistance, where a patient uses an inflatable ball, or sometimes I use rolled up towels to put under their chin. And then they do kind of a chin tuck against the resistance of the ball, where they're really trying to use those submental and suprahyoid muscles to kind of tuck the chin in to compress the ball. If you're interested in using an exercise like that in this patient population, I might look up the chin tuck against resistance, is what it's called. Of course, absolutely.
Okay, I have some question about speaking vowels. Okay, so I want to ask you, Melissa, that we have a patient who have speaking vowels, right? So I just wonder that how long for the training that we use with the speaking vowels in one patient. So like we don't observe that the patient not not tired from training with the speaking walls, but do you have any evidence or just a research that how long the period that we use for the speaking walls training? Thank you.
That's a great question. Um, I think it depends somewhat on the patient. So there are some patients, I think head and neck cancer patients are the ones who come to mind because they typically have healthy lungs. Spinal cord injury patients as well, who also typically have healthy lungs, where you can put that speaking valve on and the patient tolerates it very well the first time. All their vital signs are stable. They're able to phonate. They're comfortable. They're happy. Those patients, I usually hang out for 20 or 30 minutes and make sure that they're comfortable and that they're not getting fatigued. It is a little bit of a challenge for the patient who's used to just breathing through an open trach to overcome the resistance of that one-way valve. So it does sometimes make them a little bit tired. A patient who's cognitively intact, before I leave them alone with the valve and say they can wear this whenever they want, I want to make sure that they understand the safety requirements. So I want them to demonstrate, hopefully via teach back to me, that they know that the valve, or the cuff, excuse me, if they have a cuff, has to be fully deflated. I want to make sure that they know that they should not wear it to sleep. And I want to make sure that they can take it on and off themselves so that they could self-rescue if they did become short of breath. So I will usually practice donning and doffing the speaking valve with the mirror with those patients. And then I will usually talk to nursing and say, hey, this patient's now wearing the speaking valve, please check on them and make sure that they're comfortable with it. If it's an outpatient, I would talk to the spouse or the family and make sure that they are kind of keeping an eye on that person. So that's group one, healthy lung people who do great with the valve on the first time. You can spend 20 or 30 minutes with those patients and they are good to go. Critically ill patients are a different story. Patients with respiratory failure or pneumonia or severe COVID-19, something like that. Those patients are often only able to tolerate the valve for a few minutes the first time. And in those patients, I usually set up a plan of care. We're going to see you 4 times a week or 5 times a week. And we're going to come back and work on increasing your endurance and increasing your ability to tolerate this valve. So in those patients, we may wear the valve for 2 minutes total on the first time. And we spend most of our session with them getting comfortable with cuff deflation. And then the second visit, they may wear it for 5 minutes. The third visit, they may wear it for 10 minutes. But we're working on increasing their endurance to overcome the resistance of the valve when they breathe. We're working on them being able to tolerate it from a standpoint of their oxygen saturation, their respiratory rate, their heart rate, whether their breathing looks labored. And it really can be a slow training process in that group. We're also looking for them to not have back pressure, so trapping of air. When I say back pressure, I mean that you remove the valve, not when the patient is coughing or forcefully exhaling. You just take the valve off and you'll hear this like psh of air coming out of the tracheostomy tube. That patient is not tolerating the valve. They're stacking air up behind it. And they're at risk for hypercarbia because they're inhaling through the valve, but they're not fully exhaling and blowing off their carbon dioxide. So to answer your question, again, it really varies widely based on the patient and their needs. It could be a one-time visit, or it could be a series of short trials as the patient builds up their endurance. Does that answer your question?
Yeah, thank you very much. That's a very good answer. Yeah, I'm always clear about the periods of the training. Thank you very much. Yes.
Thank you. I wanted to talk a little bit about the different settings in which we might work with patients with tracheostomy. So I made this graphic to show kind of the acute hospital phase, the rehab hospital phase, and outpatient follow-up. I know that some of you work in a rehab hospital, and I think some of you work in acute care. Do any of you work with patients with tracheostomy in the outpatient setting? So patients who are at home, but they just come into your clinic for an appointment?
I think no, not often.
Okay. So mostly acute care and rehab hospital, very good. So in the acute phase, so a patient who has probably a new tracheostomy and we're seeing them for the first time, we do patient and family education on the function of the tracheostomy tube, which really helps with patients' anxiety about their new airway. We may do that initial cuff deflation if patients are able to tolerate it. We may do speaking valve trials if the patient is able to tolerate it. And we will do a swallow evaluation if the patient is appropriate. So that clinical bedside swallow evaluation, maybe a dye test, hopefully a FEES. And we may get the patient started on some exercises or swallow techniques in the acute phase. For a patient who's moved out of acute care and into rehab, we're moving towards promoting their independence. So if they're still using the cuff at times, cuff inflation and deflation, suctioning themselves if they're going to have a long-term tracheostomy, and again, emphasis on oral care. We want to work on taking that speaking valve on and off and making sure they understand the safety precautions. And we want to really train them to be as independent as possible with their swallowing compensatory strategies and with swallowing exercises. I won't talk too much about outpatient follow-up, but again, that's monitoring their progress with swallowing, reevaluating when appropriate, adjusting their home exercise program, and monitoring their appropriateness for decannulation. Sometimes patients who leave the hospital with the tracheostomy, do get lost to follow-up. So it's important, if you have a patient come in to see you who hasn't been seen by anyone in months and they still have a tracheostomy, I'm really thinking about, does that patient still need this tracheostomy? And if you think maybe they don't, that would be a good conversation with their primary physician or their pulmonologist. And speaking to the other therapists in the group, I really want to empower you to start those conversations and to reach out to your physician colleagues because you're spending a lot of time with the patient. And sometimes it's appropriate for us to say, hey, I think this patient might benefit from a smaller tracheostomy, or I think they might benefit from a speaking valve, or gosh, this patient has been using a cap on their tracheostomy for 3 weeks. Do they still need it, or could they be decannulated? A team approach to caring for these patients is just critical. And so I want to empower all of you OTs in this group to take an active role in the management of these patients. Because this part 3 about the evaluation and treatment was a little all over the place, I made a little flow chart to talk about how I approach patients with tracheostomy in acute care. When we get a referral for a patient with a new tracheostomy who the physician would like to have evaluated for swallowing, I start with the chart review. So again, just to recap, that age over 70 with lower functional reserve could mean higher risk for dysphagia and aspiration, maybe. I look at their baseline functional status. Did they have dysphagia before? Do they have other risk factors for dysphagia, like their critical illness or head and neck cancer? I look at the reason for the tracheotomy. So did they have a prolonged intubation or a traumatic intubation? If so, their likelihood of having dysphagia and aspiration is increased because we know that prolonged intubation can damage the larynx. And then I want to know the age of the tracheotomy. Did they just get it yesterday? Have they had it for 2 weeks? Was it a percutaneous dilational trach that usually heals up faster with less trauma? Or was it a surgical trach that might be sutured in place and that might need more time? After I do my chart review, if I think the patient is appropriate for a swallow evaluation, I want to confirm that the physician has cleared them to eat and drink. That's very important. Hopefully, if they ordered us, it's because they want the patient to eat and drink. If the patient is on mechanical ventilation, I want to know what ventilation modes and what settings. So I'll either go in there and look at the ventilator myself, or I'll give the respiratory therapist a call and find out what the plan is for this patient. If they are moving to more independent ventilation modes like pressure support, that person might be a good candidate for a swallow evaluation. I want to know the type of trach. So is it cuffed, cuffless, fenestrated? Is it a specialty trach because of an unusual airway anatomy that could affect swallowing? I want to know the cuff status. Have they had the cuff deflated yet? And I want to know the patient's respiratory status. What's their respiratory rate, their oxygen saturation? Have they had a recent chest x-ray? How does it look? I'd like to know their level of alertness and how well they're mentating. And I want to know about secretions. So are they having to be suctioned every 20 minutes? Or are they, only being suctioned once or twice a day? They're pretty dry. And I want to consider if they're ready for cuff deflation. And are they ready for a speaking valve trial? If so, I might do that before I do my swallow evaluation, since cuff deflation and the presence of the speaking valve could improve the patient's likelihood of success during the swallow evaluation. Connie, was there a question in the chat just now? Come back to that in a moment. So an optional screening test that I might do with the patient, particularly if I think that they might not be ready for an instrumental evaluation, I might do a modified Evans blue dye test. And if they fail, if they have return of blue dye, I would consider waiting and trying again in a day or two, particularly if that patient is critically ill or they're unlikely to be able to use compensatory strategies. If they pass my modified Evans blue dye test, then I might go ahead and do a FEES with that patient or a video fluoroscopic swallow study, depending on the patient and the situation. Sometimes we don't do the modified Evans blue dye test at all. We go straight to a FEES. That's more common these days, I would say. Sometimes the modified Evans blue dye test is nice on patients who are afraid to have a FEES or reluctant to have a FEES, or patients who have some upper airway issue that prevents them having a FEES. So sometimes we have patients who have had a flap, so skin taken somewhere else in the body, to repair a fistula between the nasal cavity and the oral cavity. Those patients cannot have FEES. I might start with the blue dye test for them before I take them down to radiology. Other possible interventions that I might do prior to a FEES, cuff deflation, speaking valve trials, if they're able to tolerate cuff deflation or they have a cuffless trach. So the white boxes here are kind of your optional boxes, and the yellow boxes are a critical part of the workflow. Next, I would move on to an instrumental evaluation, ideally a FEES. I would try multiple conditions if appropriate. So a valve, if they're able to tolerate it, or finger occlusion or capping. And during my FEES, I want to take the time to try compensatory strategies and various bolus volumes or bolus viscosities. And during or after my FEES, I want to do a lot of patient education about the findings and the recommendations. I think, just speaking to you from my heart, it's easy as clinicians who work with these patients all the time to take for granted what a scary and unusual experience this is for a patient who's maybe never seen or heard of a tracheostomy before. So I think it's important for us to take time to invest in that education with the patients, helping them understand their new airway, their new anatomy, to listen to them. They're often very anxious. Our breath and our anxiety and our mental status is really closely correlated. So these patients are often anxious. I think it's important to take the time to go slowly, talk them through every step, make sure they're breathing comfortably, make sure they understand as well as possible. These patients really take a lot of time, and I think it's important as clinicians to give that time to those patients. Next steps after the FEES would be to implement a swallow exercise program, respiratory muscle strength training. So inspiratory muscle training or expiratory muscle strength training, if indicated, can be useful in this population. They have adapters for tracheostomy for some of the expiratory muscle strength training devices. I want to do patient and family education, and I want to collaborate with the patient's medical team to recommend steps toward decannulation if I think it's appropriate for that patient to be switched to a cuffless trach or to be downsized. I want to be on the phone calling that physician saying, hey, In your opinion, do you think it might be appropriate for this patient to be moved along the trajectory towards decannulation um, if they're not expected to permanently need a trach? Connie, were there a couple of questions in the chat during this slide?
One is, what is the criteria to make sure that the T-tube patient is able to start swallow training with oral diet or any drinks?
Mm. I think for a patient with a tracheostomy tube, ideally, I would want to evaluate them with a FEES and make sure that they are not aspirating on a FEES. At a minimum, I would want to make sure that they pass a blue dye test and that they're awake, alert, they're managing their own secretions. But I think that statistic about the high rates of silent aspiration in this population really tell us that we should be doing FEES on these patients whenever possible. Does that answer the question?
The second question is, do you have experience with inspiratory muscle training device to apply with speaking valve?
Oh, that's an excellent question. I should say that I personally am not an expert in this topic. I only recently was trained in respiratory muscle strength training. I went to a course about it, but I haven't used it a lot. There are adapters to use the inspiratory and expiratory muscle strength training devices on the trach. I don't think it's compatible with the speaking valve. So I think you would have to take the speaking valve off while the person is doing their exercises for inspiratory and expiratory muscle strength training. But that should not be a problem. So it should not be an issue to remove the speaking valve to use the respiratory muscle strength training device. Great question.
Okay, it's me. Hello, Melissa.
Hi.
The question is about the inspiratory muscle training. I like to know that when you use the speaking valve, the is a one-way valve, right?
Yes.
Is that the air cannot in or cannot out? Sorry.
So it's a one-way valve, so you can breathe, the patient can breathe in through the tracheostomy tube.
Yeah.
When they breathe out, it closes and the air goes through the mouth and the nose.
Okay, I see. And the meaning that I asked you about the IMT, the IMT is have a small hole to a big hole. If the patient try to use the speaking valve, then it feel like they have to try the IMT together. I mean, you take off the speaking valve and then you input the small hole to try the patient who's exercise the inspiratory muscle from the big hole. And then if the patient getting better, you try to release the hole to a small hole. And then if you use the one-way valve again, if you use the speaking valve again, the patient, I'm not sure that the patient should be getting better when you use the speaking valve.
One thing I would mention about the speaking valve compared to the inspiratory muscle strength training devices is that the speaking valve does have a little bit of resistance for the patient to overcome, but it's a very small amount of resistance, whereas the inspiratory devices really are a lot of resistance. That's a lot of work for the patient. And they have a way that you can set a threshold, so a minimal amount that the patient has to be able to breathe in to activate the device. So I would think that using inspiratory muscle training would, in fact, improve a patient's ability to tolerate a speaking valve and wear it for longer. I'm just not sure. I'm not sure if the adapters on the valve are designed to be used at the same time. Does that answer the question, kind of?
Yes, so it's okay. Okay, yeah, thank you.
Yeah. I apologize. I should say that I don't have a lot of experience using the inspiratory muscle strength training devices, but I know that the literature out there about them is very supportive. So I think if you are using those, that's fantastic.
Okay, thank you. That's why the speaking valve is our newest device that I just know today from you. Thank you very much.
Yeah, thank you. I wanted to talk about just one more topic about preventing aspiration pneumonia that is separate from dysphagia evaluation and dysphagia treatment. We know from Dr. Logeman's work and Dr. Langmore's work and others that aspiration pneumonia is not just about dysphagia and aspiration. And we know it's also about oral care, dental status, ambulation, secretions. So there's things that we can do for our patients who have tracheostomies besides dysphagia evaluation and treatment to help prevent aspiration pneumonia. We can educate them on doing really thorough oral care. They may not realize that even though they have this airway, their mouth and their nose is still connected. A lot of patients forget to brush their teeth in the hospital. We want to encourage them to do that. Or I've had many patients who are edentulous who say, I don't have any teeth. I don't need to brush my teeth anymore. And so education for those patients about keeping their oral mucosa clean and healthy is really important. Encouraging patients to get up and move, to ambulate if they're able to, or to work with physical therapy and occupational therapy to move. And we can talk about basic safe feeding techniques. So sitting upright, only eating when alert, not eating if they're short of breath. And for patients who have gastroesophageal reflux, physicians, this is really important in this population. A lot of these patients who are getting aspiration pneumonia, or aspiration pneumonitis, it's not necessarily from the food and drink that they're eating. It can be from extraesophageal reflux. So there are all these other things that we as therapists and as clinicians and as physicians can be encouraging with our patients besides the dysphagia evaluation that will help prevent aspiration pneumonia in this group. Connie, did you have a comment?
Oh, no, I just found by Mr. Google, inspiratory muscle strength training devices are not reliable with the speaking valve.
Okay. Thank you for looking that up.
You're welcome.
That was the first thing I was going to do when we got off today. Another thing that we can talk to patients who are going home with a tracheostomy about is humidification. So this is an external humidification device, but they can also use a room humidifier, and even encouraging them to drink water has a big impact on the quality of their secretions. So keeping their secretions thin helps keep the tracheostomy tube clean, and it helps prevent mucus plugs that can be really dangerous in this population. So if we have patients who are going home with the tracheostomy, we want to teach them about humidification and make sure that they are attending to that important concern. After decannulation, so here's a picture of a patient who's had their tracheostomy removed and they just have the stoma. It's best practice to keep the emergency supplies at bedside for about 48 hours in case they fail decannulation and need to be retrached. We want to teach patients to, so after they've had the tracheostomy tube removed and they just have the stoma here, it needs to be dressed with clean gauze. And we can teach patients to, using their clean hands, to brace that gauze bandage when they cough or when they're speaking or when they're swallowing to help that stoma heal faster so they're not forcing air through that stoma. Something that is done in some hospitals is to stick an adhesive button from cardiac telemetry. So a little white adhesive tab that has a little button on it on the outside of the gauze. And that helps the patient kind of find it. So when they reach up, they can feel the center of the bandage to brace it when they cough or speak or swallow. We can educate the patient about what to expect. It may close rapidly. I read a statistic that some stomas lose about 50% of their size in the first 12 hours after decannulation in patients with a recent tracheostomy. Often I find that it takes about 3 or 4 days. In patients who have had the tube for a long time and who have a mature tracheostomy tube tract, it may take weeks to close completely. Patients who have had radiation to this area or some other tissue damage may take a long time to close, and they may occasionally require surgical closure. So if you encounter a patient who had their tracheostomy tube removed 3 months ago and they still have a hole there, you want to contact that patient's surgeon or encourage them to follow up with their physician to pursue closure. That's very rare, though. That's uncommon. And I want to talk about a partnership, again, on that topic between therapists and physicians, since I know this is a mixed group of therapists and physicians, about how we can work together to progress patients towards decannulation. There is some research out there in acute care hospitals about tracheostomy teams. And that research showed that when a multidisciplinary group of physicians, respiratory therapists, nurses, and therapy professionals who are working with the patient meet and have rounds to talk about patients with tracheostomy, it decreases the time to when they're able to have a dysphagia evaluation and to take food and drink. It decreases the length of their hospital stay, and it decreases the time to that patient being decannulated. So if this is something you're able to do at your facility, I would really encourage trying it. So you get together and talk. Is this patient ready for transition to a cuffless trach? Could their trach be exchanged for a smaller tracheostomy tube so that they're better able to talk and move air in their upper airway? Do we want to try a speaking valve with this patient? Could we try capping this patient's trach during the daytime when they're awake? Or maybe we say this person's been tolerating a cap for 3 days. Can they have that trach removed? So I, again, just want to encourage every professional who is knowledgeable about tracheostomy and who is working with this group to collaborate in the best interest of the patient. Any questions before I go on to part 4?
There is a question, why people with tracheostomy tube usually are found to have GERD?
Ooh, that's a good question. I don't know the answer to that, and I've actually looked into this before because it does seem to be very common that these patients have reflux. I think it probably has more to do with the underlying conditions, that these are often older patients who may have, esophageal dysmotility or a less patent lower esophageal sphincter. They're not healthy overall. They've often been reclined flat in bed for days or weeks, maybe getting tube feeding through their stomach, which causes reflux. And we want to work with those patients on being more upright during the day, being alert, interacting with the world. If you've been on a ventilator, you're sedated, you're flat all the time, you can't get up and interact with the world. Once you've been liberated from oral tracheal intubation and transitioned to a tracheostomy tube or off the ventilator entirely, it's time to start sitting up. And that alone can help with some of the management of GE reflux. I don't know why exactly patients with tracheostomy tubes have GERD, but it seems like often they do. And I would suspect it's underlying comorbidities. That's a great question. In part 4, I know we're getting down to the last 20 minutes or so, but I do want to take a look at these because I think you all will enjoy it. My partner, I mentioned earlier, is a head and neck cancer surgeon, and he provided me with some photos of some of his patients with tracheostomy tubes. And I thought that they would be a good opportunity for us to look at these photos and talk about the patients and why they may or may not have dysphagia and what we could do, treatment-wise with these patients. I will preface this with these are all pictures from surgery. One of them in particular is a little bit bloody. I apologize if anyone is sensitive to that. You may want to look away, or I'll let you know when we switch to that one. This is a patient in the operating room. This patient has tongue cancer. He has had a surgical tracheotomy. So we talked about the 2 types, dilational and surgical. This is a surgical type. In preparation for a large tongue resection. So this patient is going to have most of their tongue removed, and they're going to have it reconstructed with a free flap of skin from their forearm. And I think the blue marker on the side is where they have some enlarged lymph nodes, so they're also going to have a neck dissection. So what's pictured here is a brand new surgical tracheostomy. This patient is sedated, they're under general anesthesia. And I should mention these patients have given their consent to have their photos used for educational purposes. This is an armored endotracheal tube that's actually sutured to the patient's chest for use during surgery. It's armored because the surgeons are going to be in this patient's airway with sharp instruments, and they want to make sure they don't actually nick the endotracheal tube and compromise the airway during the surgery. So this patient, this is the very beginning of the procedure. They've marked where the neck dissection is going to be. They've done the surgical tracheostomy. They've got the airway going, but they haven't had the tongue resection or the arm flap done yet. And I thought this was a great example, when we're talking about, does a tracheostomy cause dysphagia? In this patient, it's probably not the tracheostomy that's causing their dysphagia, but they have a big cancer on their tongue and they're about to have part of their arm in their mouth. So this is a patient who is certainly going to need a dysphagia evaluation when they're cleared for intake of food and drink by the surgical team. And again, these surgical cases, I may not know all the answers to the questions, but if you have any questions, feel free to jump in. The next picture I'm going to show, I believe, is the one that's a little bit bloody. If you're sensitive to that, you may want to minimize the screen for a moment. So this is a patient who had a reconstruction of their mandible, of their jaw, with a fibula free flap. So they had cancer in their jaw was removed, part of their leg was removed. Oh, I just lost my screen sharing. Can you all still see my screen?
No.
Let me try that again.
Maybe it was too much and somebody shut you.
Yeah, okay, sorry about that. So this patient has had part of their leg implanted in their jaw, basically, for cancer treatment. And the staples here, they also had a neck dissection. So they had some lymph nodes removed from their neck, and there's a few drains in place. This is a patient who developed a rapidly expanding hematoma in their upper airway. And the ICU physicians initially tried to orally intubate the patient, but the ICU physicians were unable to do that because they were unable to visualize the vocal folds. So this patient was rushed to the operating room for an emergent surgical tracheotomy. And again, the tracheotomy itself may or may not be the cause of the dysphagia, but certainly a large hematoma that occludes most of the proximal or of the upper airway could be a reason that this patient has dysphagia. And the fact that they just had their mandible reconstructed could be a reason that they have dysphagia and are at risk for aspiration. I will say, I worked with this patient. She did very well once they drained the hematoma. She had a few days of not being able to swallow, but she actually did very well and is out in the community functioning, eating and drinking today, to the best of my knowledge, last time I saw her. Any questions about this case? Okay. You can't quite see the tracheostomy here. It's kind of under the surgeon's hand. In fact, they might be holding the airway in that picture. I can't quite tell. This is suction here. Okay. So the next one, this is a different type of patient. This is a ICU patient who is critically ill, and you can tell that this patient has had some bleeding and that they're maybe a little bit jaundiced from their color. This was a patient who required a tracheotomy for respiratory failure. So they were orally intubated for a period of weeks, and the ICU team wanted to convert them from oral intubation to mechanical ventilation via a tracheostomy for their respiratory failure. But they were not a candidate for a percutaneous dilational trach because they had a thick neck, essentially, with a lot of adipose tissue in the neck. So this patient was taken to the operating room for what's called a defatting procedure. So the surgeons essentially removed some extra fat from the area where the tracheotomy needed to go. Here you can see, I believe you can see some of the strap muscles here, and I think this might be the cricoid cartilage, and they're getting ready to put the airway in there right under the cricoid cartilage. And you can see, again, here's an airway that's inserted into what will eventually be the tracheostomy. So this is a patient who doesn't have an upper airway problem, but they are critically ill with respiratory failure and they require a trach. This is another patient who would probably benefit from a swallowing evaluation because of their critical illness and their respiratory failure, not necessarily their anatomy. So that's it for gory pictures. Anyone who had their screen closed is welcome to come back. I'm on a page of references now that is just text on a page. So these are my references. And again, thank you to, excuse me, sorry. Thank you to Dr. Ponto for providing those images of those cases. And now I think we have about 14 or 15 minutes left for questions. And I just put my contact information up there in case anyone wants to contact me with any questions or comments or feedback about today's presentation.
Or invitation to Thailand.
Yes, I would love to visit you in Thailand. And in fact, Dr. Ponto would like to visit you as well. So, do you all have any questions? Dr. Wanapai, I saw your comment. Thank you very much. All right, well, with no questions, perhaps you all have a little bit of extra time in your morning before you have to go see your patients this morning. Thank you so much for having me. It's really an honor to get to speak to your group. I enjoyed it tremendously last time and enjoyed it again this evening. And I would love to hear from you with any questions or feedback. So.
Thank you very much, OT from various side. Any question from Melissa? Very clear learning today, you know, very clear explanation in my opinion. Ajahn Sushila, any question from you?
No. I think the information is good and very clear.
Thank you.
I did send a question to Casimir Valva of a Thailand distributor because they do not note that on their website. So we'll see. But I will take one over with me to show them.
Wonderful.
Yeah.
Wonderful, Connie. And if there is no further question, we can finish a bit earlier today. Super clear lecture, and we are happy to hear from the expert once again. Thank you.
Amazing
Thank
teacher.
you kindly.
Amazing teacher. You should go on the road, Melissa.
I would love to.
Yeah, amazing indeed. Yeah. Thank
Thank you
you
so much.
Thank you. Have a wonderful day.
You too. Send me your
Yes.
slides.
Okay, I will.
Okay. Take care. Good luck Monday.
Thank you.
We'll
Bye-bye.
talk soon. Bye-bye.
Talk soon.
Bye bye, Melissa.